Welcome back to Clinically Clear, guys. Today we'll be covering some short topics, but it can come as 5 marks and 3 marks questions in your theory papers. So let's start with the first one, that is mucormycosis. So mucormycosis, you might have heard of it as black fungus disease during COVID times, etc. So it is a rapidly spreading fatal fungal infection which involves the nose and the paranasal sinuses. Okay, it is rapidly spreading, it is caused by a fungus, it can be fatal. Etiology involves two things: risk factors and causative organism. The causative organism is mucor. Mucor belongs to the class of Mucorales. Basically, it comes under zygomycetes. That is why mucormycosis previously used to be known as zygomycosis. And mucor has aseptate broad hyphae compared to aspergillus, which will have narrow septate hyphae. That is important. That is the causative organism. Which fungus causes mucormycosis? Risk factors: immunosuppression. It can be because of organ transplant patients on immunosuppressant therapy, cancer chemotherapy, HIV or AIDS, prolonged steroid therapy, etc. Then also uncontrolled diabetes mellitus. In uncontrolled diabetes mellitus, because of ketoacidosis, there is a lot of acidic environment in our body, right? This acidic environment favors the growth of fungus. So that is another risk factor. So immune suppression and uncontrolled diabetes mellitus or ketoacidosis. Also high iron content in the body. High iron content in the body also promotes zygomycosis. So people on people on excessive blood transfusion or intravenous iron therapy, even they are at risk of developing mucormycosis, which was previously known as zygomycosis. Then why is it rapidly spreading? Because it it is fatal. Why is it fatal? Because it rapidly spreads from your nose and the paranasal sinuses to the orbit, to the brain, to the meninges, to all the surrounding tissues because of its high affinity to blood vessels. It has a high affinity to the endothelium of the arteries and the vessels, so it can rapidly spread everywhere. That is the pathogenesis. Next, coming to the clinical findings. It is known as black fungus disease. Why is it known as black fungus disease? It is known as black fungus disease because of the black necrotic debris that fills up the nasal cavity. The nasal cavity has a lot of this black fungal necrotic debris. Along with that, as I said, it is rapidly invasive and spreading. So it causes excessive tissue destruction. It causes erosion of the surrounding walls and the palate. So those are the clinical findings. As you can see in this picture, you can see the black necrotic debris. It has eroded the lateral wall of the nose and it is eating away the soft tissues of the face. That is the clinical findings. Then you have the treatment. Treatment is antifungals like IV amphotericin B. We need to treat it immediately. It is an emergency. You shouldn't wait. You can't give oral therapy and all. You can give oral posaconazole, which is a drug that is commonly used now. But IV amphotericin B was what traditionally used, liposomal formulation or any other formulation, intravenous amphotericin B. Oral posaconazole and surgical debridement of the black necrotic tissue. As I said, the nose is filled with that black fungal necrotic debris. You have to surgically debride it and treat the underlying risk factors like the immune suppression, the uncontrolled diabetes mellitus. These risk factors need to be eliminated. So mucormycosis, what is it? Rapidly spreading fatal fungal infection caused by mucor of Mucorales belonging to zygomycetes. It has aseptate broad hyphae. Risk factors: immune suppression because of organ transplant, steroid, cancer chemotherapy, or HIV, and also uncontrolled diabetes mellitus, which causes an acidic environment due to ketoacidosis, promoting fungal growth. Because of its high affinity to the endothelium of blood vessels, it is rapidly spreading to the surrounding tissues like brain, orbit, and meninges. Clinically, we can see that the nose and the paranasal sinuses contain a lot of this black necrotic fungal debris. That's why it is also known as black fungus disease. Along with that, you can see the erosion of the surrounding walls, lateral wall of the nasal cavity, the septum, the palate, etc. You treat it with intravenous amphotericin B, liposomal formulation. You can give oral posaconazole. You can surgically debride out the black necrotic tissue and you can treat the underlying risk factors. Next, coming to rhinosporidiosis. Now, rhinosporidiosis is also a chronic granulomatous infection of the nose. inflammation of the nose. Here it is caused by an organism known as Rhinosporidium seabury. Rhinosporidium seabury. Now, it is not a fungus. Traditionally, they used to think of Rhinosporidium seabury as a fungus, but it cannot be cultured like other fungi. It is actually a protestin. It is a protestin parasite. It belongs to a family known as drip. This drip stands for D for some organism, R for some organism, I for something, P for something. I don't think that is important. Maybe you can check the textbook and find out. But it belongs to a family known as drip. And this Rhinosporidium seabury, it is commonly found in contaminated waters. So spread also when it can affect both animals and humans. Very, very important. Rhinosporidiosis is seen in both animals and humans. So these ponds or these water bodies that are commonly frequented by animals, it can lead to animal to human transmission. So contaminated waters is very, very important in Rhinosporidium seabury. Now the life cycle of Rhinosporidium seabury is important. Basically what happens, the infective form is something known as trophocyte. This trophocyte has a chitinous cell wall similar to fungi. It has clear cytoplasm. It has a vesicular nucleus with nucleoli. That is how a trophocyte appears. What happens in this trophocyte? The cytoplasm gets divided into, the cytoplasm divides, the nuclear divides, forming multiple small endospores. These multiple small endospores, they make up the sporangium. So this develops into a sporangium. Sporangium is double walled. You have an outer chitinous cell wall and you have an inner cellulose cell wall. Inner cellulose cell wall. And within the sporangium, you have thousands and thousands of these endospores. So what happens eventually, the endospores, they accumulate and they apply pressure on the wall of the sporangium, right? This causes the sporangium to burst, releasing out all the endospores. These endospores once again germinate to form the trophocyte. This is the life cycle of Rhinosporidium seabury. Clinically, what will you see? You will see a pink leafy polypoidal mass in the nasal cavity. It is either attached to the septum, it is attached to the lateral wall, wherever it is in the nasal cavity, you'll see a pink to purple, highly vascular leafy polypoidal mass. Now, because it is highly vascular, it bleeds very, very easily. High rate of epistaxis. So sometimes the only presenting complaint can be epistaxis, but if it grows large enough, it can even cause symptoms like nasal obstruction. So pink leafy polypoidal mass. And diagnosis, how will you do? You will take a biopsy of that lesion, the growing leafy polypoidal mass. If you see these sporangium with multiple endospores, as you can see in this picture, then it is definitely rhinosporidiosis. And how do you treat it? There is no medical cure. You can only surgically excise the leafy polypoidal mass and you have to cauterize the base to prevent recurrence. There is no effective, very, very effective treatment, medical treatment for rhinosporidiosis. You have to surgically resect the mass and you have to cauterize the base to prevent recurrence. So rhinosporidiosis, chronic granulomatous inflammation caused by Rhinosporidium seabury, found in contaminated waters. It is a protestin. So trophocyte, chitinous cell wall, vesicular nucleus, nucleoli, clear cytoplasm. Division takes place, forms multiple endospores, forms a sporangium, outer chitinous cell wall, inner cellulose wall, then multiple endospores. Because of the pressure, it ruptures, releases the endospores. Endospores germinate, forming trophocyte once again. Clinically, pink leafy, highly vascular polypoidal mass in the nasal cavity easily bleeds, hence epistaxis, can cause nasal obstruction. When you take a biopsy, if you see the sporangium with a lot of endospores, then it indicates rhinosporidiosis. Treatment is surgically excision of the polypoidal mass with cauterization of the base to prevent recurrence. So this is about granulomatous infection, very short video. I hope you guys understood. If you have any doubts, let me know in the comments. Thank you for watching.